Good morning, doctors. Today we are on to our 19th day of reading Oxford Handbook of General Practice, and I'm Dr. Sesha, your study buddy, and we are preparing for MRCGP AKT International Exam. So let's start studying. Today we are continuing from page number 417. Specific kidney diseases. Adult polycystic kidney disease. Autosomal dominant disease 1 in 1000. Cysts develop in the kidney causing gradual reduction in renal function. Common cause of CKD presents with hematuria, urinary tract infections, abdominal mass. 30% have cysts in the liver and pancreas too. Lumbar or abdominal pain and or raised BP may be associated with mitral valve prolapse and SAH, berry aneurysms. Ultrasound scan shows large kidneys with multiple cysts. Refer to a renal physician if CKD grade 3 or 5. Treat the infections and the high BP. Check with family members. Though the cysts may not be seen in less than 30 years, you have to check with the family members. 45% progress to ESRD by the age of 60 years. Associations are mitral valve prolapse, SAH and berry aneurysms, subarachnoid hemorrhage or berry aneurysms. Medullary sponge kidney. The developmental abnormality of the medullary pyramids of the kidney characterized by dilatation of the renal collecting tubules. So, it is more common in males than females. There may be a family history of medullary sponge kidney. Most are asymptomatic and the condition is an incidental finding. If symptomatic, presents with UTIs, renal stones, hematuria. Refer if symptomatic. Usually prognosis is very good and most require no treatment. Renal vein thrombosis. Causes are nephrotic syndrome. 15 to 20% of the cases develop renal vein thrombosis, membranous glomerulonephritis, acute dehydration. So, this is procoagulative state, nephrotic syndrome, membranous glomerulonephritis, and acute dehydration. Presentation varies from no symptoms to severe pain in the loin and loin tenderness. Suspect at-risk individuals is unexplained loss of renal function and RBCs in the urine. Refer to a renal physician for further investigation. Renal artery stenosis. Causes are atheroma, fibromuscular hyperplasia in the young. Presence with high BP may be severe or drug-resistant hypertension. Vascular disease elsewhere in the body, abdominal bruit, increase in creatinine, decrease in EGFR and proteinuria. If bilateral or extensive, renal failure may be precipitated by dehydration. If it is a bilateral renal artery stenosis, then renal failure may be precipitated by dehydration, low BP or drugs like ACE inhibitors initiation or NSAIDs. Refer to a renal physician if the diagnosis is unsure or vascular surgeon if diagnosis is known. Okay, Alport syndrome is an X-linked or autosomal disease, congenital sensory neural deafness, hematuria, proteinuria and renal failure. These are the 4 features of Alport syndrome. It is a familial condition, X-linked or autosomal disease in which the patient is having proteinuria and hematuria, finally leading to renal failure. Associated with sensory neural deafness, associated with lens abnormalities also, platelet dysfunction and high BP. Causes are ESRD by third. It causes ESRD by third decade in the 30 years. In males and females, rarely develop ESRD. Renal failure does not recur after transplantation. So they are good candidates for renal transplant. Renal stones. 12% of the males and 3% of females will develop renal stone at some point. Peak age is 20 to 50 years. Symptoms are not dependent on the size of the stone. Risk factors. Family history. There's increased risk, 3 times risk. Specific conditions are X-linked nephrolithiasis, cystinuria and hyperoxaluria. Anatomically abnormal kidneys. So, X-linked nephrolithiasis. Cystinuria will cause cystine stones. Hyperoxaluria will cause oxalate stones. In these cases there will be family history of renal stones. Anatomic abnormalities of the kidneys, like when there is a horseshoe kidney or a medullary sponge kidney, can lead to renal stones formation. Metabolic diseases like gout, the uric acid stones are there. Hypercalcemia, hypercalciuria, calcium phosphate stones. Cystinuria, renal tubular acidosis or other acidosis, ileostomy, adenomatous polyps also cause renal stones. Oxaluria or amino aciduria also cause renal stones. So these are the metabolic diseases. And then finally dehydration causes stones, immobilization and chronic urinary tract infection. Chronic urinary tract infection predisposes to stone formation. Drugs predisposing patients to stone formation. So these are the drugs causes of nephrolithiasis: acetazolamide, allopurinol, aspirin. Allopurinol causes uric acid excretion and uric acid stones. Aspirin, steroids, indinavir, nelfinavir, loop diuretics. Loop diuretics causes excess uric acid excretion. Probenecid, same as causes excess uric acid excretion. Quinolones, sulfonamides, theophylline, thiazide diuretics again cause uric acid excretion. Triamterene, antacids, calcium vitamin D supplements, high dose vitamin C. See, calcium supplements can lead to high calcium excretion and then calcium phosphate stones. High dose vitamin C is also one cause. Presentation. Usually presents with pain plus nausea, vomiting. Location and type of the pain gives clues about the site of the stone. Loin pain is a kidney stone. Renal colic is a ureteric stone. Strangury is a bladder stone. And interruption of flow, urethral stone. Renal colic. We will read these types of pains in detail. Symptoms. Severe pain with waves of increasing severity usually starts abruptly as a flank pain, which then radiates around the abdomen to the groin as stone progresses down the ureter. May be referred to testis or the tip of the penis in a man, or labia majora in women. So loin to groin pain to the tip of the testis or tip of the penis or the testis or labia majora in women is typical of renal colic. Signs. Patient is obviously in pain, unable to sit and keep shifting position to try to get comfortable, in contrast to peritonitis where patient tends to keep still. May be pale or sweaty. May be mild tenderness on deep abdominal palpation or loin tenderness, although are often minimal signs. So you won't be able to elicit tenderness in case of colic due to renal nephrolithiasis or renal stones. And if fever is suspected, if there is fever, you suspect an infection. Other presentations are UTI, hematuria, urinary retention, renal failure. So these are the other presentations of renal stone, renal colic. Differential diagnosis: pyelonephritis, uh, ruptured aortic aneurysm, cholecystitis. See, ruptured aortic aneurysm, again left-sided abdominal pain will be there. So left renal colic can be left renal side pain can be a renal colic on the left side, or ruptured aortic aneurysm, pyelonephritis, or cholecystitis when it's on the right side, pancreatitis, appendicitis, diverticulitis, obstruction, strangulated hernia, testicular torsion, petidine addiction. So these are the differential diagnosis in various quadrants, because the stone, after leaving the kidney, it will go into the ureter and pass down towards the bladder. So they are in different quadrants, so bilateral. So different differential diagnoses are there. So immediate investigations. Dipstick urine if possible. Absence of RBC does not exclude a renal colic, but consider alternative diagnosis. Immediate management. Stones usually pass spontaneously. Give pain relief diclofenac 75 mg IM or 100 mg PR plus antiemetic. Consider admission if there is a fever. Consider admission to a hospital if, in case of renal colic, if there is fever, oliguria, poor intake of fluid, pregnant, lives alone, Uncertain diagnosis, analgesia is ineffective or short-lived and symptoms more than 24 hours. If not admitted, encourage increased fluid intake, sieve urine for stones, monitor or review pain relief and for complications. Further investigations can wait until the next working day and include, so it doesn't have to be immediate investigations. You can do blood blood test, urea electrolytes, creatinine, EGFR calculation, calcium and phosphate levels, alkaline phosphatase levels, uric acid and albumin. Urine, microscopy and culture sensitivity and RBCs. Consider checking spot test for urine cysteine and albumin creatinine ratio, calcium, phosphate, uric acid and sodium excretion. Radiology, X-ray of the kidneys and ureters and bladder. 90% of renal stones are radio-opaque. Only urate and xanthine stones are radiotranslucent. Renal tract ultrasound will be required. Follow-up. 50% occur in 5 to 7 years. Recur in 5 to 7 years. Give general advice on prevention of the stones. Table 13.5. If investigations show any loss of renal function, renal obstruction or remaining stones, refer to urology. Dependent on composition of the stones, give dietary advice or refer to a dietitian. Hyperoxaluria. Hyperoxaluria may be primary autosomal recessive condition or secondary to gut resection or malabsorption or dietary excess of spinach or vitamin C. Take a specialist advice on management. There are two types of primary hyperoxaluria. Type 1 hyperoxaluria, calcium oxalate stones are widely distributed throughout the body. Presence as renal stones and nephrocalcinosis in children. 80% have chronic renal failure in less than 20 years. This is type 1. And then type 2 hyperoxaluria are more benign but less common. Nephrocalcinosis but no chronic renal failure. So hyperoxaluria is a metabolic condition, so it is autosomal recessive condition. See, we have read that autosomal dominant conditions are mostly structural. Autosomal recessive conditions are mostly metabolic. Not that one of them is more severe than the other. Autosomal recessive conditions may be more severe as they are metabolic. Cystinuria. Most common amino aciduria. Usually, because cystine is an amino acid, right? So, most common amino aciduria usually present with stones at 10 to 30 years of age. Urine cystine content is more, ornithine content is more, arginine content and lysine content is more. So, urinary amino acids is more. Cystine, ornithine, arginine and lysine. Take a specialist advice on the management of cystinuria. Hypercalcemia. Hypercalci is present. We have read that on page 336. Hypercalciuria may occur without hypercalcemia and is found in 80% of the patients with calcium oxalate stones. So whenever you have calcium oxalate stones, you need to check whether it is because of increased calcium or increased oxalate. So hypercalciuria occur without hypercalcemia. It's found in 80% with calcium oxalate stones. Prevention of renal stones. Types of stones, preventive measures. All types. Increase the fluid intake. Prevention of renal stones. The type of stone and preventive measures. All types. Increase the fluid intake more than 2 to 2.5 liters per 24 hours, especially in hot weather. Decrease the weight if obese. Decrease animal protein intake and increase the fruits and vegetable in the diet. Decrease the salt content. Calcium oxalate stones. Urinary alkalination with potassium citrate. Avoid chocolate, tea, rhubarb and spinach. Nuts, beans, beetroots. This is for oxalate stones. You have to alkalize with potassium citrate, give Uralka. Avoid chocolate, tea, rhubarb, spinach. Spinach has more oxalate content. Nuts, beans, beetroot. Decrease the citrus fruits. Bendroflumethiazide, thiazide diuretics. OD may help if hypercalciuria is present. Hyperoxaluria is treated with pyridoxine. So, calcium oxalate stones can be due to either hypercalciuria or hyperoxaluria. So, for if there is established hypercalciuria, then bendroflumethiazide will help, and if there is hyperoxaluria, is treated with pyridoxine. Calcium phosphate stones. Low calcium, this is triple phosphate stones, is staghorn stone. Low calcium phosphate stone. Low calcium diet would help. Avoid vitamin D supplements. Bendroflumethiazide 2.5 mg OD may help if hypercalciuria is present. So, even if your diet is high in, even if you have circulating high calcium levels, if it is not filtrated into the renal tubules, then there will be no calcium phosphate stone. So, that's why they are giving bendroflumethiazide to prevent hypercalciuria. Staghorn or triple phosphate stones, calcium, magnesium and ammonium phosphate stones associated with UTI due to proteus species and urinary stasis, example due to anatomic abnormality. Treat UTI with antibiotics. Urate. Avoid beer as has uricosuric effect. So whenever you have a urate stones, you need to avoid beer. Allopurinol, urinary alkalization with potassium citrate, that is more than pH more than, keep the urinary pH more than 6.5. Keep it alkalinized. Cysteine, urinary alkylation with potassium citrate. Cysteine stones, urinary alkylation with potassium citrate. Page number 420. Hematuria, bladder and renal cancer. Hematuria, bladder and renal cancer. Hematuria, blood in the urine. Detected on urine dipstick, more than 1 plus blood on urine dipstick is significant. Causes are in table 13.6, may be visible or frank or non-visible or microscopic up to 20% of the population. Non-visible hematuria may be symptomatic, example with dysuria, increase in frequency of urination, or non-symptomatic, usually found by chance. Investigation of all cases of hematuria, check the blood pressure, palpate the abdomen, send a midstream sample for microscopy and culture sensitivity. So all cases of gross hematuria or microscopic hematuria, you need to check for BP, palpate the abdomen and send midstream sample for microscopy and culture sensitivity. Free hemoglobin and myoglobin make urine test sticks positive in the absence of red cells. Urine discoloration can also result from beetroot ingestion. Porphyrias, bilirubin secondary to biliary obstruction, or drugs. Example, rifampin. If the cause is identified, sample taken when menstruating, UTI, repeat or check for blood in urine once treated or resolved. So whenever there is a hematuria, then you have to do a repeat sample for blood in urine after it is treated, UTI is treated or resolved. Refer urgently to urology. When? To be seen within 2 weeks. 2 weeks referral, that is for suspecting cancer. If with a child with unexplained hematuria, consider admission if unwell. Age more than 45 years with unexplained visible hematuria without a UTI, or visible hematuria that persists or recurs after successful treatment of UTI. Age more than 60 years with unexplained non-visible hematuria plus dysuria or raised WCC count on a blood test. So either there is non-visible hematuria or microscopic hematuria plus either dysuria or a raised WCC count, then and the age is more than 60, you need to refer within 2 weeks. And age is more than 45, then visible hematuria, which persists. Further primary care investigation. If urgent referral is not indicated, check the renal function test, urine sample for albumin creatinine ratio or blood for EGFR. Consider PSA testing plus DRE for males with visible hematuria. Refer for pelvic ultrasound if females, age more than 55, visible hematuria, plus unexplained vaginal discharge, reduction in hemoglobin, increased platelets or increased blood glucose. Refer for renal ultrasound if visible or persistent non-visible hematuria or persistent non-visible hematuria on more than one urine sample. So you need to refer for a ultrasound if there is any visible hematuria and not going on the high risk criteria for urgent referral, then you will refer for a ultrasound. Non-urgent referrals. Urology or gynecology. Age more than 60 years plus recurrent or persistent UTI. Urology. Any age plus unexplained visible or symptomatic non-visible hematuria or age more than 40 and asymptomatic non-visible hematuria. So microscopic hematuria which is persistent and more than 40 years, you have to refer somewhere. So if more age is more than 40, you refer to non-urgently to urology. If it is more than 50 years, 45 years, then you refer to urgently to urology. And if it is more than 60 years with any of these conditions, then you refer urgently to urology. Nephrology. If eGFR is less than 30 ml per minute or evidence of declining GFR, significant proteinuria ACR more than 30 milligrams per millimole, age is less than 40 years with isolated hematuria without proteinuria, plus high BP, visible hematuria coinciding with intercurrent infection, usually a upper respiratory tract infection. There's a visible hematuria with upper respiratory tract infection, you need to refer them to nephrology. If ongoing persistent NVH without proteinuria or CKD, follow up one time per year with BP, urine dipstick for hematuria and ACR and eGFR till it resolves. If there is persistent non-visible hematuria, microscopic hematuria without a proteinuria or CKD, then follow up one time in a year annually with BP, urine dipstick for hematuria if it's present or disappeared, ACR and eGFR. Causes of hematuria. Causes could be infectious, UTI, urethritis, prostatitis, TB, schistosomiasis, infective endocarditis. Tumor, bladder cancer, prostate cancer, kidney cancer, endometrial cancer, Wilms tumor. Inflammation, glomerulonephritis, Henoch-Schönlein purpura, IgA nephropathy, Goodpasture syndrome, polyarteritis, and post-irradiation. Structural, stones like renal, bladder or ureteric stones, cysts, simple cyst, polycystic renal disease, BPH, congenital vascular abnormalities, blood, sickle cell disease, coagulation disorders, trauma, surgery, catheter, foreign body, sexual activity, abdominal or back injury, drugs, sulfonamide, cyclophosphamide, NSAIDs. So cyclophosphamide will cause hemorrhagic cystitis. Others like menstruation, fabricated or induced illness. Did you start? Oh. Sterile pyuria. White cells in the urine without UTI. Repeat with clean catch MSU. If persists, refer to urology. So when you can find white blood cells in the urine microscopy without any UTI, that is the leukocyte esterase and nitrates are not positive, but they are white blood cells. Then repeat with clean catch midstream urine sample. And if it is still persisting, then refer to urology because the causes could be different. Inadequately treated UTI, appendicitis, calculi, prostatitis, bladder tumor, renal tuberculosis, papillary necrosis, UTI with failure to culture organism, interstitial nephritis or cystitis, polycystic kidney disease, chemical cystitis, example due to radiotherapy. Bladder cancer. Incidence. 11,000 cases per year in the UK. Males more than females 5:2. Transitional cell carcinoma is the most common in UK. Squamous cell carcinoma is most common worldwide. Risk factors are smoking. Half male cases are attributed to smoking, aromatic amine exposure like textile or rubber industries, stasis of the urine, chronic UTIs, schistosomiasis, presence with hematuria. That is why hematuria is so important to evaluate, because most of the bladder cancer will present with hematuria. Recurrent UTIs, less commonly presenting with recurrent UTIs, frequency of urination, pelvic or loin pain, or bladder outflow obstruction. Investigations and management. Midstream urine sample excludes UTI and detects sterile pyuria. Check the urine dipstick for non-visible hematuria. Refer to urology to be seen within 2 weeks. Treatment depends on stage and diagnosis. Table 13.7 Stage of bladder cancer treatment and prognosis. Stage Type T1. Disease is confined to the submucosa or mucosa, treated with transurethral resection of the tumor, TURB T plus single intravesical chemotherapy. Very good, mostly die from other causes. T2. Invasion into the connective tissue around the bladder. Treatment is with TURB T plus radiotherapy. 60% survive 5 years. T3. Invasion through the muscle into the fat layer. Treated with radical cystectomy or radiotherapy. 40 to 50% survival in 5 years. T4. Spread beyond the bladder. TURB T for local symptoms and palliative radiotherapy or chemotherapy for distant metastasis. 20 to 30% survival 5 years. Investigation and management. Urine, RBCs. In the urine there will be blood. RBCs, blood. RBCs. Blood, there will be raised packed cell volume, 2% cases, PCV, anemia, hypercalcemia. Radiology. Ultrasound scan, chest X-ray. Refer to urology to be seen in less than 2 weeks. Treatment includes surgery where possible, plus chemo, radio or biological therapy. Overall 50% 5-year survival rate. Hypernephroma, clear cell adenocarcinoma of the renal tubular epithelium. Clear cell adenocarcinoma of renal tubular epithelium. Incidence is 9,300 cases per year. Okay, this is less than bladder cancer but almost equivalent, 9,300, and that one is 11,000. Typical age 50 years. Males more than females 1.5 to 1. Spread can be local or hematogenous. Bone, liver, lung causes cannonball metastasis on chest X-ray. So cannonball metastasis is caused by hypernephroma or clear cell adenocarcinoma of the bladder. Presentation: hematuria, abdominal mass, loin pain, anemia, left varicocele in males, and occasionally night sweats. Why particularly left varicocele? Because there is a connection in venous drainage of the left kidney and the left testis. Information and support for patients. Page number 422, urinary tract infection. This is a very commonly asked and tested topic on MRCGP. Urinary tract infection is one of the most common conditions seen in general practice, accounting for up to 6% of consultation, one in case in average surgery. So, females more than males, 20% women at any time have asymptomatic bacteriuria and 20 to 40% women will have a UTI in their lifetime. Infective organisms are E. coli 70%, Proteus species, Pseudomonas species, Streptococci and Staphylococci. Risk factors: when there is a prior infection, it's a risk factor. Diabetes, stones, pregnancy, dehydration, GU instrumentation, genitourinary instrumentation, catheterization, decreased estrogen as in menopause, sexual intercourse is a risk factor, GU malformations, urinary stasis, example obstruction, delayed micturition. So whenever you are on long journeys, you have to make sure you micturate timely. When you are on long journeys and there's delayed micturition, it's a risk factor for urinary tract infection. Presentation of UTI. Cystitis. If UTI can be cystitis, pyelonephritis, or urethritis. So cystitis, frequency, dysuria, presence with frequency, dysuria, urgency, strangury, low abdominal pain, incontinence of urine, acute retention of urine, cloudy or offensive urine, or hematuria. Pyelonephritis. So still higher up in the urinary tract. Loin pain, fever, rigors, malaise, vomiting and or hematuria. Dysuria and urgency, painful micturition resulting from urethral or bladder inflammation. So dysuria is not present in pyelonephritis because um, as explained below. Dysuria and urgency are symptoms of either urethritis or cystitis. Painful micturition caused from urethral or bladder inflammation. Causes are urinary tract infection, urethral syndrome, inflammation, interstitial cystitis, radiation-induced cystitis, intravesical lesion, either a tumor or a stone, or atrophy due to menopause. Frequency of urination. Passage of urine more often than usual. Causes are urinary tract infections, urethral syndrome, detrusor instability, inflammation, interstitial cystitis, fibrosis, post-radiotherapy, atrophy, menopause. After menopause, neurogenic bladder as in multiple sclerosis, external pressure, example pregnancy or fibroids, bladder tumor or stone, enlarged prostate, drugs like diuretics, diabetes, excessive fluid intake, and habit. Initial investigations. If uncomplicated UTI is present in an otherwise healthy female, test the urine with a leukocyte and nitrate dipstick. If positive, treat for UTI. Reasons to send for MSU for microscopy and culture sensitivity. So, initial investigation. If you are thinking the female patient has no other risk factors for uh, any complications of UTI, then you just check whenever you check for a leukocyte and nitrate on dipstick, and if it is positive, then start the antibiotic. But then if you suspect there is a complicated UTI, then say you send for microscopy and culture in the following phases. Unresolved infection after antibiotics. So initially, if an uncomplicated UTI, 3 days of antibiotic. So after 3 days of empirical antibiotic, it is not resolved, infection is not resolved, then you send for urine for microscopy culture sensitivity. Recurrent UTIs are present. Uncatheterized male with no UTI. So usually males are not susceptible to UTIs. So if there is a male with a UTI, you have to send for microscopy and culture. Catheterized male or female with symptomatic UTI. So when there is catheterization, definitely there will be some infection present. But if they are symptomatic on catheter, then you have to send for microscopy and culture. Impaired renal function is there. In a child, you have to send for, every time you have to send first sample for microscopy and culture, then start empirical antibiotics. Pregnant woman, sample for microscopy and culture sensitivity, empirical antibiotics. Suspected pyelonephritis, send for microscopy and culture sensitivity. Hematuria, if you can find in urine dipstick for leukocyte, nitrate and hematuria. So, if at all hematuria is present, either microscopic or macroscopic or on dipstick, always investigate further by microscopy and culture sensitivity. Abnormal renal tract history is there. Take midstream sample prior to starting antibiotics, send the laboratory fresh. Further investigation. Consider further investigation with blood tests, that is EGFR plus or minus PSA if patient is more than 40 years and males. So male patient more than 40 years, you have to check for if there is any urinary infection, you send for microscopy culture sensitivity, and then you send for EGFR and PSA testing or radiology, example renal ultrasound, when if UTI in a male patient. So as we have discussed before, so when you have to send for EGFR testing, PSA sample in males and renal ultrasound, UTI in a male patient, UTI in a child, recurrent UTI in a female, unclear diagnosis, persistent symptoms but negative midstream sample. Pyelonephritis, so symptoms are persisting of UTI, but there is microscopy is negative, so you will send for a ultrasound. Pyelonephritis you are suspecting, unusual infecting organism, sterile pyuria, that is WBCs in the urine. In that case, you have to send for ultrasound. Management, catheterized patient, 427 we will see. Children 856 we will read when we are reading pediatrics. Pregnant women 798. All other patients other than catheterized, pregnant or children, they have a different protocol for management. All simple UTIs, symptomatic relief with paracetamol and NSAIDs, increase fluid intake, prescribe oral antibiotics, example first nitrofurantoin MR 100 milligrams BD or trimethoprim 200 milligrams BD. Consider local guidelines for resistance. 3 days course for females with uncomplicated UTI. So this is a 3 days course for of nitrofurantoin or trimethoprim for females with uncomplicated UTI. Consider delayed prescription if mild symptoms are there. 7 to 10 days course for males, or if GU malformation or immunosuppression, relapse of same organism or a recurrent UTI from a different organism. So then you give a longer course, 7 to 10 days course. For males, you always give a longer course because males are not usually susceptible to UTIs, and if they have a UTI, it should be from a what we can say, a potentially dangerous organism. That's why you give for 7 to 10 days course of antibiotic. Use a 7 days course of quinolone. When do you use quinolone for? Urinary tract infections. 7-day course of quinolone, ciprofloxacin 250 milligrams or 500 milligrams BD for pyelonephritis. So when there is suspicion of pyelonephritis, then you will give 7 days course of quinolones. Otherwise, trimethoprim and nitrofurantoin. Refer for urology if abnormalities are detected on further investigation or unable to resolve the symptoms. Admission is rarely needed in a UTI. Prevention of recurrent cystitis. Reinfection after successful treatment of infection 90% or relapse after inadequate treatment. General advice. Advice to urinate frequently. Increase the fluid intake. Double void again, go again after 5 to 10 minutes and void after intercourse. Prophylactic antibiotics. Consider prescribing either postcoitally, example nitrofurantoin MR 100 mg stat, or continuously trimethoprim 100 mg or nitrofurantoin 50 mg nocte. So continuously you give a low dose trimethoprim or nitrofurantoin half dose. Trimethoprim 200 is normal dose. You are giving half dose. Nitrofurantoin 100 milligrams is normal dose and you are giving half dose. So postcoitally also you can prescribe when there is recurrent cystitis. Men with BPH. Finasteride, dutasteride or doxazosin decrease the UTI because that will decrease the retention of urine and subsequently decrease the UTI. HRT. Topical estrogens decrease the recurrent UTI in females of all ages. Vaccines. Results of large-scale trials are awaited. Prostatitis. 430. Chronic pyelonephritis. 416. Urethral symptoms. Symptoms of cystitis with negative MSU. Urethral syndrome is symptom of cystitis with a negative midstream sample of urine. Unknown cause associated with cold, stress, nylon underwear, COC pills and intercourse. Advice fluids 2 plus and to wear a cotton underwear. Consider changing or stopping COC pills or trying a topical estrogen cream if postmenopausal. Tetracyclines, example doxycycline 100 mg BD for 14 days or azithromycin 500 mg OD for 6 days are helpful in some. Not settling, refer to urology. Interstitial cystitis, predominantly present in middle-aged females, can cause fibrosis of the bladder wall. Main symptoms are frequency, urgency, pelvic or suprapubic pain, especially when the bladder is full, often misdiagnosed as recurrent UTI. MSU, no bacteriuria, refer for urology to confirm. There is no satisfactory treatment, although antispasmodics, amitriptyline, bladder stretching under DGA may help in some patients. Incontinence of urine, page number 424. Involuntary loss of urine which is demonstrable on social or hygienic problem. 1 in 3 with incontinence consult at the outset, 1 in 3 consult later, 1 in 3 suffer in silence. Opportunistic questioning can identify sufferers. History. frequency of complaint, volume passed, degree of incapacity, whether occurs with standing, coughing or sneezing, urgency or dysuria or frequency of micturition, past obstetric and medical history, medication, mobility and accessibility of toilets. Examination. Abdominal examination including a direct rectal examination. There is an enlarged bladder, masses, loaded colon, fecal impaction, anal tone, pelvic prolapse, atrophy, neurological deficit, retention of urine and pelvic masses. You have to examine both abdomen and the pelvis. Pelvis, you have to check whether there is any genital prolapse and atrophy, neurological deficit is present, retention of urine is present, or pelvic masses. Investigation. Intake or output diary at least 3 days including working and leisure days, evaluates problem and benchmark for progress, records drinks and passage of urine, RBCs, microscopic culture, consider for blood for urine exam, blood for urea and electrolytes, EGFR, FBC, fasting blood glucose, HbA1c if renal impairment or diabetes is suspected. Drugs that exacerbate cause incontinence. So, diuretics, antihistamines, anxiolytics, alpha blockers, sedatives, hypnotics and anticholinergic drugs, tricyclic antidepressants. They have TCS have anticholinergic side effects. Sedatives and hypnotics, alpha blockers, anxiolytics, antihistamines and diuretics. These are the drugs that exacerbate or cause incontinence. GP management in urinary incontinence. 30% have a mixed pattern. Treat according to the dominant symptom. Try general measures before referring to urology or gynecology for further investigations. General measures. Manipulate fluid intake, amount, type. Avoid tea, coffee, alcohol, timing. Promote weight loss. After medication, timing of diuretics. Alter the medication, that is timing of diuretics. Treat the UTI and chronic respiratory conditions that is causing cough. Avoid constipation. Consider a hormone replacement therapy, topical or systemic, for estrogen deficiency. Consider a scheduled voiding if cognitive deficit is present. Referral only when there is these conditions are satisfied. Aids and appliances for incontinence. Nocturnal enuresis alarm in children. Nocturnal enuresis in children. Stress incontinence. Symptoms. Small loss of urine without warning throughout the day related to coughing or exercise. Causes are prostatectomy, childbirth, deterioration of pelvic floor muscles or nerves. Treatment. Pelvic floor exercises continued more than 3 months help 60%, taught by physiotherapists or continence advisors. Leaflets are available. May be assisted by vaginal cones or electrical stimulation. Mechanical devices like Contrali ActiveGuard, FemSoft may help. Referral for incontinence problems. Specialist continence advisor or DN. Advice on aids or appliances, advice on primary care management, patient support. Urodynamic studies. So initially you have to go for advice and primary care management and patient support. Then urodynamic studies. If the type of incontinence is uncertain, atypical features of incontinence is present after a unsuccessful surgery. If a neurological problem is suspected, then you go for urodynamic studies. Gynecology or urology opinion. GP management has failed. Severe symptoms or pain is present. Recurrent UTIs. Recurrent UTIs, concomitant gynecological problems like a prolapse, concomitant urological problems like chronic retention, prostate abnormality or rectal examination, failed incontinence surgery, pelvic radiotherapy, vesicovaginal fistula or hematuria is present. then you have to refer to gynecology or urology for opinion. Urge incontinence. It's an overactive bladder syndrome. The detrusor instability or hyperreflexia causes the bladder to contract unintentionally. Symptoms are frequency, overwhelming desire to void, often precipitated by stressful events, large loss, and nocturia. It is not dribbling, it is full urination. And there will be nocturia in this case. Even in night, in middle of the night, there will be urge incontinence. Causes: idiopathic neurological problems like stroke, multiple sclerosis, diabetes, spinal cord injury, dementia, and Parkinson's disease. Local irritation, bladder when there's a local irritant like bladder stone, bladder cancer, infection, obstruction like BPH, surgery, TERP. These all can cause urge incontinence in people. Treatment: bladder training. Resist the urge to pass urine for increased periods. Start with an achievable interval based on diary evidence, and increase slowly. Continue for more than 6 weeks. So if you have to continue this type of treatment for 6 weeks. If bladder training is ineffective, try oxybutynin first line. So oxybutynin is not a treatment for stress incontinence. It's a treatment for urge incontinence. Alternatives are solifenacin, tolteridone, trospium, and duloxetine. Solifenacin, tolteridone, trospium, and duloxetine are other alternatives for urge incontinence. Spontaneously remits or relapses, reassess every 3 to 4 months. Overflow incontinence. Constant dribbling, loss day or night. So causes are BPH, prostate cancer, urethral stricture, fecal impaction, neurological lesions, low motor neuron lesions, side effects of medication. Causes overflow incontinence. Treatment is aimed at relieving the obstruction. So there is some kind of obstruction to complete voiding. So there will be continuous dribbling day and night because of overly filled bladder and improper urination, improper voiding. Urinary fistula. Communication between the bladder and the outside, normally through the vagina, results in constant dribbling day or night. Refer to gynecology and urology. Causes congenital malignancy, complication of surgery. Functional incontinence. There is no urological problem caused by other factors like inaccessible toilets or immobility, behavioral problems, cognitive deficit. Treat the cause. 426. Aids and appliances for incontinence. So now we have seen the types of incontinence. One is stress incontinence, second one is urge incontinence, then third one is overflow incontinence. So aids and appliances for incontinence. Many different types are present. Pads. Many different types. DNs or convenience advisors are best aware of those available by the NHS locally. They are not available on the FP10 and supplied by local NHS trusts on a daily allowance basis. This varies across the country. Bed covers. Absorbs 1 to 4 liters of urine. Good laundry facilities are needed. If left wet, can cause skin breakdown. Available via the NHS trust. External catheters or sheets can be prescribed on the NHS prescription. Approved appliances are listed in Part IXB of the UK drug tariff, used for men who have intractable incontinence and who are highly physically dependent, do not have urine retention, and do not require internal catheter. Do not have urine retention and do not require internal catheter. So in them, external catheters or sheets can be used. Used in association with a drainage bag. Assessment and fitting by a DN or incontinence advisor is essential. May be non-adhesive or self-adhesive or attached via adhesive strips. Adhesive sheets can last several days, but daily changing is recommended. Replace non-adhesive sheets 2 to 3 days. Some are reusable. Problems include increased susceptibility to UTI, sores on the penis, skin irritation due to adhesive. Catheters. Catheters can be prescribed on the NHS prescription. Approved appliances are listed on Part IXA of the UK drug tariff. Indwelling catheters. Only use catheters in patients who have urinary retention or a neurogenic bladder dysfunction, not for other types of incontinence. So, urinary retention, neurogenic bladder dysfunction, severe pressure sores, inoperable obstructions that prevent bladder emptying, terminal illness, housebound without adequate care or support. Urinary retention, severe pressure sores, inoperable obstructions, terminal illness, and housebound with inadequate care. Types. Only long-term Foley's catheter are suitable for use in primary care. They last at least 3 to 12 weeks. Catheter size. Unless specified, a 12 or 14 ch catheter is supplied. The use is the smallest diameter of catheter that drains the urine effectively. Catheters more than 16 ch are more likely to cause bypassing of urine around the catheter and urethral strictures. Catheter length. Men require longer catheters than women. Specify male or female on prescription. Catheter balloon. 10 ml balloons are supplied unless specified otherwise. Pre-filled catheters contain sterile water which inflates with retaining balloon water with water. They are more expensive but quicker to insert, and there are no cost of syringes or sterile water. Okay. Insertion. This procedure is given in 429. Drainage. Usually attached to a leather leg bag, although catheter valves are also available, allowing the patient to use his or her bladder as a urine reservoir. The valve must be released every 3 to 4 hours to drain out the urine. Common problems. Leakage. Check no constipation. Check catheter not blocked. Try smaller gauze catheter. Infection. 90% develop bacteriuria less than 4 weeks after insertion. Always confirm suspected UTI with MSU. Only treat if symptomatic or proteus species is grown. May prove difficult to eliminate. No good evidence of bladder installations help. Encrustation. Deposition of minerals and other materials from the urine into the catheter. Worse, if there is infection with proteus, may cause catheter blockage or pain changing the catheter. Check pH of the urine regularly in patient with problems. Citric acid patency solutions may help if pH is more than 7.4 or a daily dose of vitamin C. Inflammation. Results from physical presence of a catheter in the urethra, exacerbated by incrustation and infection. There is no easy solution. Try a different brand catheter, hydrogel catheter rather than a silicone catheter. Blockage. Change the catheter. The interval of routine changes should be altered if there is regular blockage towards the end of life of a catheter. Intermittent self-catheterization. Patient inserts a catheter into his or her bladder 4 to 5 times a day to drain the urine. Decreases the problem of infection and blockage. Useful for neurological bladder dysfunction. For neurological bladder dysfunction, intermittent self-catheterization. Types are reusable silver or stainless steel. Reusable PVC catheter washed and reused for 1 week. Usually supply 5 per month. Single use needs 125 or 150 per month. Expensive. Only use on consultant advice. Collecting bags. Can prescribe on NHS prescription. Approved appliances are listed. Tariff leg bags. Drainable bags last 5 to 7 days, usually 500 to 750 ml. Larger capacity bags are too heavy for mobile patients. A variety of attachment systems are available on prescription. Long tubes are needed to wear a bag on the cuff. Night drainage bags. Connect to a night bag attachment of day bags. Single use, disposable non-draining bags are recommended. Bag hangers are not available on NHS prescription. Enuresis alarms, page 893. So we will stop here for today, and tomorrow we will continue from page number 428. Urinary tract obstruction. Thank you friends. Have a good day.